Imagine standing at the edge of a roof, looking down at the street below, and stepping off because you genuinely believe you can fly. In clinical psychiatry, an action like this is evaluated objectively. It is a catastrophic failure of a highly specific cognitive function, judgment. This illustrates the healthy state of that function. Clinical judgment is a cognitive engine built on three sequential pillars: the capacity to correctly assess a situation, the ability to make an appropriate decision, and the foresight to comprehend the consequences of that action. A disorder of judgment is the impairment of this exact framework. The cognitive process fractures, resulting in decisions that are illogical, socially inappropriate, or life-threatening. Recognizing this disorder requires stripping away our subjective opinions about what constitutes a bad choice. Clinicians do not judge morality. They measure neurological and psychological processing against a rigorous clinical standard. To prevent catastrophic outcomes, clinicians treat judgment as a complex cognitive engine that can be mapped, measured, and medically managed. To evaluate this engine, clinicians use a three-part Venn diagram to separate interactions into distinct domains. The first domain is personal judgment, governing self-care. A clinical failure looks like a patient refusing to eat properly despite a severe illness. The second domain is social judgment. This regulates environmental appropriateness and behavior modulation. A patient failing here might shout loudly or crack jokes during a highly somber or serious situation. The third domain is test, or hypothetical judgment. This is a metric of abstract reasoning, where clinicians assess a patient's proposed response to standardized imaginary scenarios. The classic textbook prompt for this domain is straightforward. What will you do if you find a stamped, addressed envelope lying on the road? A patient may have entirely intact personal judgment, feeding and clothing themselves perfectly, while exhibiting severely impaired social or test judgment. A complete psychiatric picture requires evaluating all three. This spectrum maps the pathology gradient of judgment. Base, mild impairment, slight hesitation, seen in anxiety or depression. Next, moderate impairment, poor choices degrading daily life, linked to substance abuse and personality disorders. Top, severe impairment, highly dangerous decisions marking psychosis, mania, or dementia. The contrast between levels is sharp. A patient keeping money from a found wallet demonstrates poor social judgment. A patient impulsively draining their entire life savings in a single afternoon without a thought for tomorrow demonstrates severely impaired judgment. Correctly placing a patient on this gradient dictates the immediate urgency of the medical intervention. Once the severity is napped, the clinician has to work backwards to uncover the etiological root cause driving the cognitive failure. This node map traces impaired judgment origins. The psychiatric branch, like schizophrenia or mania, biologically disrupts logic centers. The organic branch isolates physical brain damage from injuries, dementia, or infections. The final substance-related branch shows how alcohol or drugs chemically rewire the brain. Treating a severe judgment disorder caused by a CNS infection requires an entirely different medical protocol than treating one caused by bipolar mania. Accurate etiology isolation dictates the entire treatment plan. This clipboard outlines the assessment triad, a standardized three-pronged framework used to objectively test a patient's judgment. The first vector uses direct hypothetical questions to test logic limits. A clinician will ask, "What will you do if your house catches fire?" to verify if the patient prioritizes survival and safety over trivial actions. But answers alone are insufficient. The second vector requires direct observation. Clinicians track real-time financial decisions, daily routine behaviors, and social interactions on the ward. The third vector is the clinical interview. The clinician probes the patient's history, examining past decisions, and checking if the patient actually recognizes the negative consequences those actions caused. By combining hypothetical limits, real-time observation, and historical behavioral patterns, this triad removes subjective bias and produces a medically defensible rating of the patient's judgment. Before initiating treatment, clinicians must isolate judgment from two closely related psychiatric symptoms that often present simultaneously but demand different management strategies. This split panel matrix visualizes the distinction. The top row defines insight. Insight is strictly the patient's awareness that they actually have an illness, completely independent of the choices they make. The next block defines impulse control. This is the raw, mechanical ability to resist sudden physical or emotional urges. These deficits overlap dangerously. A patient might feel a sudden urge to empty their bank account, indicating poor impulse control. They fail to realize this will ruin their future, indicating poor judgment. And they aggressively deny having a manic spending problem at all, indicating a lack of insight. When judgment and insight fail simultaneously, the patient is entirely blind to their own cognitive breakdown. At that point, the entire burden of safety shifts to the clinical staff. This staircase diagrams the strict, escalating nursing protocol required once a clinical assessment is complete. Step 1 is assessment. The immediate priority is evaluating the exact level of impairment to identify catastrophic risks, particularly suicide or physical harm to others. Step 2 is safety measures. If severe risk is identified, staff must physically prevent risky decisions and implement direct, constant patient supervision. Step 3 dictates communication. Staff must use simple, clear instructions, strictly avoiding complex choices that could overwhelm a struggling cognitive engine. Step 4 shifts into education. Nurses actively teach the patient about the consequences of their actions while integrating the patient's family into the care matrix. Step 5 is treatment support. This is the ongoing duty of ensuring absolute medication compliance to resolve the underlying etiology while monitoring the patient for cognitive improvement. Successfully managing a disorder of judgment requires the clinician to integrate assessment triad data, isolate the specific etiology, and maintain the 5-step safety protocol. This systematic process ensures the patient's physical safety while the underlying cause of the cognitive impairment is treated.